so I'll jump right into this. So to date, we've had bone marrows performed on 20 patients with DADA2 with ADA2 deficiency at NIH. So we've seen 4 major phenotypic patterns. Cytogenetics were normal in all cases. 18 of the 20 patients presented with disease in childhood or infancy. 2 out of 20 presented with adult onset of disease. 19 had compound heterozygous mutations in ADA2, and 1 patient had homozygous mutation in ADA2. So the first bone marrow phenotype is that of trilineage hematopoiesis. So we had 10 patients with this phenotype. 9 out of the 10 had a history of vasculitis or vasculopathy, and 7 out of 10 had a history of stroke. 1 presented with infections, warts, and CD4 lymphopenia. Typically, the peripheral blood in at least half of the patients had microcytic anemia with low serum iron. And 1 patient had moderate pancytopenia with microcytic anemia, and half of the patients also had mild borderline neutropenia or thrombocytopenia. And the bone marrows of these patients had active trilineage hematopoiesis. A subset had B lymphopenia, subset had increased T cells or T cell aggregates, and a subset were hypocellular for age. So this is an example of one of the patients in this group. This is the patient that had moderate pancytopenia. This patient had a history of vasculitis, had a history of 7 strokes. As we can see, for a 6-year-old, the bone marrow is moderately hypocellular for age. We can see evidence of megakaryocytes when we looked at the aspirate. We can see that the erythroid precursors are maturing nicely. We see good myeloid maturation with neutrophils here. And then when we did immunohistochemistry on the core biopsy, you can see a few scattered T cells. When we did immunohistochemistry with CD79A, we see really a marked decrease in B cells. So typically for a 6-year-old, you should usually see more B cells in the bone marrow than T cells. This now just go over what we look at by flow cytometry of the bone marrow to look at B cell maturation. So this is a normal control, and this is the lymphocyte gate. The cells that are in dark blue are NK cells and T cells. And we look at CD10 versus CD20, and these are what we call hematogones or B cell precursors. The earliest forms have very high levels of CD10. They're negative for 20. As they mature, they have moderate expression of CD10 and slowly begin to express CD20. These would be like transitional B cells, and these are the mature B cells. If we look at CD34 and CD19, the pro-B cell precursors are generally, obviously, in less quantity in comparison to the other B lineage cells. So this is another DADA2 patient. This was a 16-year-old female who had a history of CPAN, borderline neutropenia. She had active trilineage hematopoiesis, but she has very abnormal B cell maturation here. We can see a lot of early B cell precursors, but almost no transitional B cells and very few mature B cells. And when we looked at CD34 and CD19, we can see a relative increase in the proportion of pro-B cells versus the remaining number of B cells. So this pattern really looks like impaired B cell maturation in the bone marrow. The second phenotype that we saw that was we had in 6 patients were patients with severe neutropenia and myeloid aplasia or hypoplasia. 4 out of 6 of these patients had no evidence of vasculopathy or stroke. One of these particular patients had a sibling diagnosed with marrow aplasia. 2 out of 6 had a history of vasculitis or stroke, and one of these patients had a sibling diagnosed with DBA. One of these patients had normal trilineage hematopoiesis and then progressed years later. So peripheral blood features, 4 patients had an ANC of 0. 1 had an ANC of about 300, and then another of 600. Bone marrow features, 4 out of 6 had myeloid aplasia with a maturation arrest pattern, which I'll show you. by flow cytometry. And then one of these patients had almost no monocytes, had absent B cells, and this patient had severe immunodeficiency with disseminated MAC infection and was at that time diagnosed with monoMAC or DADA2 deficiency. Of this group, 2 had myeloid hypoplasia with left-shifted granulopoiesis, and 4 out of the 6 had T-cell lymphocytosis in the bone marrow with T-cell aggregates and inverted CD4 to 8 ratios. So this is an example of a patient in this group from a 6-year-old, and this is the core biopsy. We can see multiple lymphoid aggregates. This is a higher power view of a lymphoid aggregate. This is CD3 stain showing that these aggregates are largely T-cell aggregates with increased interstitial T-cells. And this is CD71 for comparison, which highlights erythroid precursors. This is MPO, or myeloperoxidase. And this is CD79A. So this patient actually did have B cells. So they're not, myeloid cells should be really typically the most numerous cell in the bone marrow. So that is definitely decreased. This was the aspirate. And what we can see is maturing erythroid precursors here, but there are very few maturing myeloid precursors. There's maybe a few precursors, but no metamyelocytes or neutrophils here. So looking at the flow cytometry, when we look at the myeloid cells in the bone marrow, we like to look at CD13 versus CD16, and we see a reproducible pattern of myeloid maturation with promyelocytes that have high CD13 and are negative for 16. As they mature, they downregulate CD13, and then myelocytes and metamyelocytes begin to express 13 and 16 when you get mature neutrophils that are high for CD16 and 13. So we call this the Nike stripe. We see it in every normal bone marrow. This was this patient's myeloid compartment, and we can see that there's really what looks like a maturation arrest here with no mature neutrophils, and we've basically lost myelocytes and metamyelocytes as well. This was the lymphoid compartment in this patient's marrow, and we can see there's inverted CD4 to 8 ratio of 3.6, and when we look at CD57, there's an expanded subset of 57 positive T cells that are consistent with an LGL phenotype. So the third pattern that we saw in the bone marrow was that of pure red cell aplasia overlapping with Diamond-Blackfan anemia. We had 2 patients with this particular phenotype. Neither of these patients had a history of vasculopathy or stroke. Obviously, there was severe transfusion-dependent anemia. One of the patients actually had progressed to having neutropenia, moderate neutropenia, with an ANC of 700 as well. And the bone marrows of these patients showed severe erythroid hypoplasia with a maturation arrest pattern. So this is an example of one of these patients. This is the patient that had severe anemia and also had developed neutropenia. What we can see on the aspirate smear is that basically we have one lone pro-normoblast with no maturing erythroid precursors. There are a few myeloid precursors and some eosinophils here. The bone marrow is markedly hypercellular for age, and we can actually see, I'll show you this better, but there are lymphoid aggregates here and a pretty intense lymphoid infiltration. This is higher power. This is CD71, which normally stains erythroid precursors. There's very rare cells that are positive here. And then this is looking at erythroid maturation in the bone marrow. So this is a normal, healthy control. Typically, we see a few erythroblasts that are positive for 117 and highly expressed CD105. And as the cells mature, they downregulate CD117. And then as they mature more, they downregulate CD105. And these are like orthochromatic normoblasts here. So this is our DADA2 patient. And we can see basically a number of immature erythroid precursors and essentially no mature forms here. So this is consistent with a maturation arrest pattern. So this was immunohistochemistry on the core biopsy. So this is MPO, and this is CD3. So normally we see a lot more MPO than T cells, so there was a really intense T cell infiltration in that bone marrow. And then this was the myeloid maturation pattern that we saw with this patient. So myeloid cells were decreased, but the maturation was still intact, unlike the other pattern that I showed previously. When we stained with CD8, the vast majority of T cells were positive for CD8, and this is a TIA1 stain, which was positive in a number of these T cells that was consistent with cytotoxic T cell phenotype. In this particular patient, there were very few B cells. So the last phenotype that we saw was that of an aplastic marrow. We had 2 patients with this phenotype. One of the patients had no history of vasculitis or stroke, but on MRI, it appeared that there had been a previously unrecognized stroke in the past. The other patient presented at 9 months with stroke and vasculopathy, had prior normal CBCs, and actually progressed to pancytopenia with severe anemia and neutropenia at the age of 11 years. Pancytopenia, actually both of these patients had mild thrombocytopenia. And they had markedly hypocellular marrows. This is the example of the younger patient, marked pancytopenia, very hypocellular marrow for an 11-year-old. Interestingly, he also had a few clusters of megakaryocytes, and this is CD3, so we do see, for this level of cellularity, this is quite a few number of T cells that are in the interstitial space. This is CD79A, he had essentially no B cells. So summary of findings, we see mainly 4 patterns in our patients at NIH, that of the active trilineage hematopoiesis, severe neutropenia with myeloid aplasia or hypoplasia, pure red cell aplasia, and the aplastic marrow. Most of these marrows have T cell infiltrates. Typically, they're CD8 positive with an increased LGL phenotype. Interestingly, TCR gamma PCR has been polyclonal or oligoclonal in all of these patients. And additionally, many of these patients are lymphopenic in the peripheral blood, although they have lots of T cells in the bone marrow. So we have not seen a definitive genotype-phenotype correlation. It appears that there is a plasticity of bone marrow evolution and that we've had patients that have normal trilineage hematopoiesis that evolved to an aplastic phenotype or to this severe neutropenia or agranulocytosis phenotype. And again, we've had someone with PRCA that evolved to PRCA and severe neutropenia. Obviously, these phenotypes may or may not be associated with vasculopathy or strokes, and we've seen phenotypic variation within families, one family having severe neutropenia and another sibling with pancytopenia or aplastic marrow, another family with severe neutropenia, and another patient, a sibling being diagnosed with DBA. So here is just my last slide, cartoon of DADA2 with normal trilineage hematopoiesis, which can evolve to normal trilineage hematopoiesis with B-cell lymphopenia, or the severe neutropenia and myeloid aplasia, pure red cell aplasia, which can also develop to have a combined severe neutropenia, aplastic marrow. It looks like we can have expansion of T cells, which may be involved in mediating either of these 2 phenotypes. And then we've also seen a severe immunodeficiency with monocytopenia in addition. Okay. Thank you.